Hi, everyone. My name is Dr. David Lin. We are here joined by Dr. Anish Kadaka and Milap Patel for the inaugural podcast episode for At Ankle Man. Let's introduce yourselves a little bit. Dr. Kadaka, do you mind?
Yeah, so I'm Anish Kadaka. I'm the ankle man, as I've kind of made myself to be on Instagram. And hopefully this is our first podcast of many, kind of talking about cases, life, all sorts of aspects of being a doctor, foot and ankle, and just kind of hope to interact with a lot of people and share ideas and thoughts and education.
Yeah.
My name is Milap Patel. I'm an orthopedic foot and ankle surgeon. I'm at Northwestern. I'm Anish Kadaka's partner. Fun fact, I was also his first fellow in his fellowship, and I stayed on as his partner. But I'm really excited about the podcast. We have a lot of interesting content to share. Really looking forward to it.
Awesome. Well, I'm glad you guys can join us in this first inaugural episode. I think there's many episodes to come. And today, I think Dr. Kadaka is going to present a case to us so we can all learn from his experience. Go ahead.
All right. Give us some grace. This is our first run. We're going to improve as we go. So one of the things I think with Instagram and when we do presentations, we always show our best cases. But this is one of those cases that I learned a lot from, and it's the case I never forget. So I want to hear from Dr. Lin and Dr. Patel, Milap and David, what you guys think. So this is not where it started for me, but it's a Weber C ankle fracture. So before we even get to what was done, quickly, what would you guys do for this? Open medially, young patient in their 30s with a Weber C. What's your fixation of choice, Milap? How would you approach this?
Yeah, this is Weber C in general. You would assume that the syndesmosis is gone. I mean, it's very clear the deltoid is also gone too here. It looks like it's probably an open injury immediately based on the soft tissue envelope and the way it looks like. I would obviously extend my incision medially a little bit more, wash everything out, repair the deltoid with 1 or 2 anchors, and then put a anatomic plate on the lateral side and fix the syndesmosis. If there is a lot of soft tissue envelope that's doesn't look good on the medial side, then I would probably just do syndesmotic screw so I don't have to put the button exposed on the medial side. But that's what I would do.
Awesome. That makes sense. And David, would you do anything different?
Probably just manage the soft tissue first, X-fix, stabilize the soft tissue. Probably stage it before I repair anything. If there's no injury in the fibular side, I might fix it at the same time as I put the X-fix and leave the deltoid for a little later. But that's about the only thing I probably do different, but standard trauma stuff to start. So
yeah, it makes total sense. I think you guys hit all the key points, soft tissue management, and then you can see what was done. So this is, again, I didn't do this, but this came to me like this in my practice. You can see there was some sort of fibular ORIF. I'll show the x-ray in a second. You can see that there were syndesmotic screws used, but it was not reduced. Fundamentally, that's the problem. Clear space is wide. And so this is what I did. So she came wide. So I did a revision of the fibula, an allograft reconstruction. I'm curious to see, maybe I was too aggressive with an allograft here, and I revised the deltoid. Problem is now she's about a year out, and you can see there's already ankle arthritis. And I have a couple questions for you guys, because you guys are both pretty smart. Like, why do you think this person has ankle arthritis so rapid? And was allograft aggressive, or would you have just done some tight ropes to revise this again?
I can go first. So, Weber C's in general require a lot of high energy injury compared to like a Weber B. So there has to be increased soft tissue damage. And also, can you go back to the injury films, Anish, if you don't mind?
Of course, man. And you can't ask, I have rules when I do presentations. You can't ask for more than what I got, because I don't know what the other images are.
There's probably a good chance there's probably some impaction onto the anterolateral distal tibia there. And if you go back to the x-ray that you showed us again, there's probably a good chance there's some arthritis that's setting in on the lateral joint. These are just inherently bad injuries to begin with, from my experience. And no matter what you do, the injury dictates what's going to happen to them. So, I mean, I think clearly initially there was clear widening of the syndesmosis, and the delta probably wasn't repaired, and that's probably why this is all happening. But at this point, I mean, you gotta do what you gotta do.
So, David, what would you do now, man? So you have a young patient, little bit of valgus ankle arthritis. I lengthened that fibula hard. Maybe you could argue it's still not long, but I can see that it's impinging in the lateral talofibular recess. So I thought I got it where it's at. I think it's a lot of joint loss laterally. I think maybe what Milap said, there's some paction, and the deltoid is now tight because it's not laterally translated. The question is, what do you do now? Your options are, I'll give you the options in my world. Ankle fusion, most reliable. Ankle replacement, for sure can be done. Allograft total ankle arthroplasty. And then you have tibial osteotomy. And then maybe distraction arthroplasty. The 5 things I can think of that would be quote unquote reasonable options for this case, unless you got a 6th one. Of those 5, unless you got a new one, what would you do?
I mean, if I see some subsidence there, I kind of tell the patient I kind of want to scope it just to kind of see it first. But if you're gonna do like a joint destructive thing, it'd probably just be an ankle fusion since the patient's a little younger. Now, if she's heavier, definitely a fusion. She's younger and she's not very active. Maybe you can get away with a total ankle with a stem. But yeah, that would be my choices here. So I will say this though, Weber C's with that high energy impact, I tend to use rigid fixation for the syndesmosis instead of flexible, because I feel like inherently they're just a little bit more stable. When I was a little younger, I did a flexible on a Weber C before, and I don't think they ever worked really well. I don't know, the patients just never did as well as if I did a rigid fixation. But that's my take on it. No papers to back that up. So,
I think a lot of what we do is level 5. I think obviously I'm a huge fan of flexible fixation with like the tightrope, but I think it requires got to be aggressive with the deltoid, maybe at an AITFL, so you're getting it significantly stable, still allowing some motion. So maybe not just for Weber C's. Milap, I think you do this too. I'll do a tightrope with an internal brace AITFL, not just a tightrope. I don't know if that in a Weber C, you're a little bit more aggressive, I think, too, or no?
Yeah, I try not to use screws. Though my indication for screws for syndesmosis are diabetic patients. If it's an open fracture, or if it's a length unstable injury, so if it's like a Mason move or like a really high fibula where I'm not going after the fibula, those are the only 3 times I would use a solid fixation. But I think reconstructing the AITFL, I mean, we use Arthrex. It's a great system to kind of lock in the fibula and into the tibia to lock in the rotation. And then the tightrope helps really compress the syndesmosis down too. So I think it's a great technique. I wouldn't say it's solid, but it's good enough.
So, the fun thing about it, there's no right way. We've published on the syndesmosis and the ligament fixation. I think it does really work well. But now look at that distal tibia. And I didn't notice this, but it looks a little sclerotic to me. I don't know if you guys kind of been looking at it now, see that lateral tibia is kind of dense. Do you see that, or am I making it up?
I see it. I wonder if, I see it.
So I wonder in these Weber C's, is that blood flow damaged a little bit? So I waited, and now you can see this. What happens is the ankle is going into more valgus. I didn't know what to do. Patient was young. My options were poor. So I said, why don't we just sit on it for another few months, wear a brace, see how it goes. No injections. But now what do? You could see now that, and this is a problem, the distal tibia is collapsing. The ligaments are where they are, but this is damage to that anterolateral tibia or lateral tibia. So now, given the same options, what are you going to do? Anything? Is it automatically now a fusion, stem total ankle? Or are you going to do anything different?
I mean, if the cartilage was not damaged, would you do like a wedge and do a subchondral? I mean, almost like an arthroplasty to bring that cartilage back down, pack it with bone graft, or would just go for a fusion, call it a day?
It looks like there's essentially AVN of the anterolateral distal tibia there. So, and because going into valgus, clearly there's joint damage too. So I'm not sure if tamping down would be ideal.
Viable.
I
Yeah.
guess this is a time where you can do a scope and see if the cartilage does look viable or not before you decide. But I think in my view, I would probably do a fusion if the patient was really, really symptomatic and nothing else was working.
I think you guys both hit it on the head. I mean, this bone is not viable. I think when you look back in hindsight, right, it's easy to look at everything in hindsight. In hindsight, something's wrong with that distal tibia. The biology of that is no good. Problem was she was 30, so I felt at this point an osteotomy might not be a bad idea. Might not. So I tried everything, bracing. I felt, and this idea was a tibial osteotomy. The issue was I don't think I recognized at the time that the bone was not that healthy. So I did a medial closing wedge osteotomy, and I thought I did a reasonable job. I did a fibular osteotomy. I had exposure, so I put a medial plate with a couple staples at the time. And you can argue and criticize all of this as you all desire, but I thought it looked reasonable. Problem is, this happened to me now. So I'm not, you can criticize all you want, but now I got a non-union, and now with CT, that bone is clearly a problem.
I'm assuming you packed it with a bunch of bone graft and all the juju you can put in there.
Absolutely. At Northwestern, I have the luxury of having an infinite biological augmentation ability. So we put that all in there at the time. At the time, this was BMP, I think. This is now 12 years ago. It's an old case. I think I used BMP with some Allosync Pure or some sort of grout to help. And it clearly did not heal. So now this poor patient has this non-union, still young. And we talked about fusion. And I think now that's what we're going for. But the question is, what would you do now? So this fusion isn't easy. So again, I will tell you, I did not recognize or believe that distal tibia was non-viable. I didn't think it was dead. So I'll skip to the good part. So I figured I would do an osteotomy, revise the osteotomy, and fuse it at the same time. The plates that many of you young surgeons now, right, because I'm 20 years out, there was not a lot of fancy, huge plates that exist. Many of the plates you use now don't exist. This isn't even on the market anymore. There's a dual plating technique. The plates didn't fit that well, so I could not get the other tibial talar plate on. So I think it's a Synthes type plate I put on there to try to get everything, grafted it, and you can see that's the X-ray. This is what we had. It was not a TTC. The subcutaneous joint was normal. So, go ahead and criticize all you want, both of you. What do you think is an issue here?
I mean, it's. I think the issue is what you said before. I think the bone was dead, and that's probably why it's going on to a non-union. The plating seems fine. It looks like it's in a neutral alignment now. Fibula non-union is not a big deal here. But I think the bone was just dead, and that's why there's no matter how much biology you put in there, I don't know if it's going to heal ever.
So I won't bother David with it. That's exactly what happened, and I think we don't sometimes, I think we don't want to recognize what's real. Yeah, and clearly this distal tibia was not healthy. So as you could imagine, screws broke, non-union. Patient still wanted to avoid a TTC, so I did call in help at this point. So I called in Dr. Kalikian, and ultimately I'll show you he saved the case. So we had we used a truss, and this is at the beginning of when truss came out. Now many of you in the audience probably don't do a truss with a plate. David, Milap, have you ever done I'm assuming you do a truss with a rod when it's actually loaded. But at the time, this was very rarely done. So we used a plate. And do you guys know, I don't think the trusses heal unless they can see load. That's my understanding now. I don't know if you guys have that experience yourself.
I don't have a bunch of experience with this, honestly.
I mean, I don't do a lot, but if I do them, it's with the IM nail. So
okay. I think what happens is so Kalikian and I didn't know. We talked to our colleagues after we did this case, And everybody who I started out with these trusts has tried something like this. And the problem is, I think you don't allow the trust to see load, and that's how these work. So ultimately, as you would imagine, we took out the dead bone, we put a bunch of biology in, but again, we had failure of union. And I think this is a technical issue. Again, we don't have a huge fat plate to use. This is all we had available at the time. And so it didn't heal. So now patient's upset, obviously. They still trust us. So Kadaka and I thought about this a little bit when I give most of the credit to Dr. Kadaka, and then he revised it with the trust. And after talking to a bunch of colleagues, nail. And we ended up doing a TTC. And so a lot of lessons here before we get to the outcome is that, one, when things aren't going well, it's good to ask friends, colleagues for help, which I did. And then even when you're friends and colleagues together, we have a huge community. That's the whole point of this podcast. So that's why I wanted to start off with this case. The whole point of this podcast and Instagram is to share ideas that we can all learn from each other instead of being in silos and, being embarrassed by things that don't work, because we all are trying very hard on these hard cases and things don't always work well unless we educate each other. How would you know? So I learned a ton that you got to use axial loading with the cage. These Weber Cs can't get avascular bone. TTC is better than a bad ankle fusion when you have these cages with the plate. So, and then he taught me this. He taught me, I don't know if you guys just, when you do a TTC, do you put them in an AFO for a long time to protect your fusion, or you just let them rock and roll?
Depend on the patient. I mean, the bone quality is not good, like a Charcot, then yeah. But I mean, if they're not, then I won't. But
I usually get a CT scan around 3 months. If there is some union or good amount of union, then I won't bother with an AFO. But if it's not robust looking and I don't trust the patient, then an AFO is my go-to.
So
I sometimes put them like a PTP brace.
That's a great option too.
Yeah, and that will take some load off. So,
no, go ahead. No, it's for me. If it's a bone block or cage, I always put them in AFO for about a year. If it's primary bone to bone, I don't put them in an AFO because I've got solid bone in between. And I don't know what the right answer is. Just Armin taught me this. So at a year, the patient finally healed. I'm going to keep going. 2 years, you can see that everything finally healed. And patient has some motion through the hindfoot and through the midfoot, not the hindfoot. And now 3 years, and we have data now, this patient for many years. So it was a salvage. Was it a great outcome? No. Was the die cast at the beginning when she presented to my office the first time? Probably needed an ankle fusion the first time. But a lot of lessons here is that, A, you never give up. Don't blame the patient. Call in friends. And keep trying hard, because you can salvage a lot of things. Now, clearly 13 years later, I've learned a lot. And so usually this doesn't occur to me as much anymore. But it's a case I've never forgotten, because there's a lot of humility here, a lot of calling in friends. You're not perfect. I'm not perfect. And that's the point of the Ankle Man podcast, is that we're not perfect. We're here to learn, get better, and, try to help our patients. So, that's the case. I don't know if you guys have any last comments for this. It's holding up years ago.
Back then was fibular osteotomizing the fibula for ankle fusion a thing?
Back then, if it was short, if you had bone loss, yes. So if you had a lot of tibial bone loss, you'd break the fibula so that it could impact a little bit. But in general, no, we were not. I don't speak for all people my age, but I don't remember being taught to osteotomize the fibula from an anterior approach ankle fusion. Like lateral approach would cut the fibula, so that didn't matter. But anterior approach, we kind of left it as is, and we never osteotomized it.
It's just for blood flow purposes, or it's just a practice back then.
Practice back then. So here's a question: like, if I do an anterior, all my ankle fusions now, unless it's a revision or MIS, as many of you know, and we'll get into that type of a case in the podcast later. But if I do an anterior approach, I still won't osteotomize the fibula. I'll take the gutters down so I can shove and get compression. But unless it's severe deformity, I don't routinely osteotomize the fibula to get compression. Is that something you do?
No, it's just a question that popped in my head. I just remember when I was training, a lot of attendings would take down the fibula and obviously do lateral plating, or even with the IM nail, they'll take it off and then tack it on like a graft or something on the side. I mean,
I think the reason why that makes sense and something we have to think about is that when the fibula is at length, the lateral process impinges on it. So as you're trying to compress, and this, for me, this is an arthroscopic problem that I faced for many years, is that when I do an arthroscopic fusion, I just do the tibio-talar superior joint, and I try to compress, but the talus is a trapezoid. I couldn't get it to go up because I'd leave the gutter. So now if I do an arthroscopic fusion, which I don't have a great indication for it with MIS, is I destroy the gutters. The last one I did, I just went in, I destroyed the gutters so I could get it to slide up and compress so the lateral process wouldn't impinge on the fibula. That's why I think when we used to do the fibular osteotomies, lateral approach, it wasn't an issue. They would just slam together.
Right.
And that may be why some of us struggled with arthroscopic fusion, because you didn't have that,
Maybe that's why they cut the fibula. Just osteotomy, let the fibula slide shorter, and then,
I think that's exactly why. That's why the MTAF technique is so nice, because it mitigates that and the whole thing slides up. But I think the concept is, you're right. We have to let the fibula has to shorten somehow, or the talus has to be independent of the fibula to get that compression, which is, I think, why some of our fusions have struggled a little bit when we don't do that.
And I think if there's any deformity, I think you should have a low threshold to do a fibular osteotomy, right? Especially if it's like a varus angulation, you should just do a fibular osteotomy in order to correct it.
Yeah, I think you're right, man. And with MIS, it's no longer a big deal.
Yeah, it's not a big deal.
Right, before you have to cut the thing. Now I just obliquely cut it, let it fly. It'll heal. Really allows you to swing. So
nice.
It was a good case.
Well, this is a very cool case. Thank you. I think we're going to end here, keep this nice and short so people can get on with their lives. And we'll keep making these episodes, hopefully weekly. Hope you enjoy this. And thank you again for being here. Docs.
Thank you very much.
Thanks, David.
Everybody soon.